right, welcome back. We are Outside the Box, an EMS podcast to drive our clinical performance here in the city of Sugar Land. You know me, I'm your host, Kevin, and I'm very excited to have with me today Amanda Humphreys. I'll get to introduce her in a minute. Very fine physician that I'm excited to discuss some of these things with. So thanks for joining us. Let's talk about you for a minute. We're going to talk about evaluating patients, but what about you first? Why don't you tell us a little bit about you?
Sure. Well, my name is Amanda. I am the current medical director for Sugar Land Fire Department, and I am from Ohio. So I think it's funny that you guys think it's cold outside. But I'm from Ohio. I did my medical school and residency up there in Cincinnati, and then I did an EMS fellowship out in Albuquerque in New Mexico. And then that brought me here to Texas. So I have experience with ground and air EMS. I flew as a flight physician back in residency and in fellowship, and have also served as the assistant medical director for another suburban fire agency back when I was in Ohio.
Fantastic.
Yeah.
So fair to say you've evaluated a patient or two?
Once or twice.
Okay, good. We got good knowledge base that we're going here.
Yeah.
Specifically today, we're talking about our shock index. Well, not our shock index, the shock index, not really ours. But
Are you taking credit for it now?
No, zero. Absolutely not. I did not come up with this. I just use it. But we're going to talk about it. We're talking about how we use it, how to make it an effective tool, and something that we roll into our assessment. Something you're very familiar with.
Yep, absolutely.
And why don't you tell us about it? What is there to know?
Sure. So the shock index is heart rate divided by systolic blood pressure. So it's heart rate over systolic blood pressure. And the thing that I love about the shock index is that it's kind of like the canary in the coal mine. It's going to be abnormal before you really notice either one of those individual vital signs as grossly abnormal.
I like the way you put that. Yes. So we'll even demonstrate some of that with our examples. But yes, this is going to be alarm bells before the alarm bells would go.
Exactly. Exactly. Yeah. And so the shock index has been around for a long time. It's been studied in hypovolemia. So like hemorrhagic shock is where we see that most often. It's also been studied in sepsis. And so when you think about those numbers, so you've got your heart rate divided by your systolic blood pressure. And so when your heart rate is higher than your systolic blood pressure, that's when you should be really alarmed. And so values of 1 or greater are grossly abnormal. Normal is about 0.5 to 0.7 for a healthy human being who hasn't just run a marathon or anything, because they're just like SIRS criteria. There are other things that can make this abnormal other than being ill. But like I said, normal is 0.5 to 0.7. Once you get around 0.9, depending on what study you look at, somewhere between 0.9 and 1 is an independent predictor of mortality. And so the thing, like I said, that I love about this is that it's really the canary in the coal mine. You've got systolic blood pressure in the low 100s, but a heart rate that's also in the low 100s. Either of those numbers by themselves might not really set off those alarm bells, but when you look at them together, that's what this number does for you.
I like it. And I think it's even, I like it, we're putting vital signs together, but now it's a step further of how are they interacting with each other.
Exactly.
'Cause it's pretty crucial to look at blood pressure and heart rate as we're evaluating hemodynamic status, but
absolutely,
we can very much so be limited if we're using 2 sets of evaluation criteria to evaluate the blood pressure and another set to evaluate the heart rate next to each other instead of how are they playing together. And let's take an example to demonstrate this, because you're talking about normal being 0.5, which means that typically the heart rate is going to be half of what the systolic blood pressure is, and we have some wiggle room in there. That our nice textbook 120/80 with a heart rate of 60 is your shock index of 0.5.
Right.
So that's what we see. And even to be a little bit more reasonable about it, a blood pressure of 120/80 with a heart rate of 80 is our 0.7, technically 0.75, but that still keeps us in our very normal range when we're talking about shock index.
Yep.
And we're going to talk about some other examples where classically we wouldn't have been concerned, but the shock index is going to say, hey, wait a minute, you might want to pay attention to this. And we'll get to those a little bit later on. But I like looking at this. I think the shock index, I always talk about hemodynamic status is kind of like the investment, how expensive things are. So a systolic blood pressure of 110, 100, 110 could be fantastic, could not. And the heart rate is the cost to me. That's how I put it in my mind. So if we have a heart rate of 80 to get a blood pressure of 110, that's a relatively inexpensive 110 systolic. Compared to a heart rate of 120 to make a systolic of 110, that's a pretty expensive 110.
Yeah.
And I kind of see shock index as the quantification of that the higher this number is, the more expensive that blood pressure is. So rather than go with the classic end of as long as the systolic is 90, you're fine.
Right.
Now we put it into much more context and it's more dynamic. And the blood pressure of 120, the systolic, may not be such a great thing depending on what we're looking at.
How much does it cost to get you there? That I haven't heard that phrased like that before, but I really like it.
I like that one. And I like looking at it, like I said, as we're treating people that are in this hemodynamic instability, we're treating the shock state and we get no changes in blood pressure. But our heart rate starts to improve and it comes down. Again, I look at it and it becomes a less expensive blood pressure, especially as we're dealing with the sick patients. And maybe 90 systolic really is, man, that's a pipe dream.
Right.
But we go from a heart rate of 140 down to 120 with our therapy. Well, heck, we're going in the right direction.
We're making some progress.
But as pre-hospital providers, we're not classically taught that. We're taught you get that blood pressure up, period.
Right.
And then we could start off the whole next discussion about pressors and trauma. And I know how you have some certain feelings about that. And how that's not appropriate course of therapy. But
I do, in fact, have feelings about that.
So I think this is what gives us better tools than to blindly go at something like that lands us in massive amounts of pressors in a trauma case that's bleeding out because the book said get their blood pressure up.
Right.
We now have a better perspective to say, hey, our therapy is effective. And while we may not hit the absolute arbitrary numbers that we want in a systolic blood pressure, we actually get a more rounded view of this patient's condition, and we can feel better about it and understand where we're going. All right, cool. So let's talk about these reference ranges again real quick, because then we're going to dive into, some of these examples.
Okay.
Normal is?
About 0.5 to 0.75.
Right. Okay. I like it. And 0.9 is where we hit that mortality range.
Depending on what data you look at, somewhere between 0.9 and 1, you've got is an independent predictor of mortality. So if you're at 0.9, you should definitely be starting to worry.
And so 0.8, are you concerned?
You should start to look closely at what's going on. I think I'm not going to sound the alarm at 0.8, but
it got your attention.
It should start to get your attention.
Okay.
And you should be recalculating this number, with every repeat set of vital signs.
Nice.
To see what direction you're going. Just like anything else, trends tell you a lot.
Mm-hmm.
If it was 0.5 and now it's 0.8, that worries me. If it was, 0.75 and now it's 0.8, well, that's margin of error.
Yeah. And as we look at that predictor of mortality, there's some good literature that says if we're ever over this 1.0, we have an increased chance of mortality. So even though we encounter this patient, high shock index, we deliver therapy, we resuscitate them very nicely, the trauma team receives them, resuscitates very nicely, and we correct the problem in there, there's still increased statistical odds against them for having ever been in that position. Right.
Just like, in head injury, any single episode of hypoxia or hypovolemia increases mortality. It's the same. It's just a measure of how sick this person is.
Yeah. And you get an amazing benefit that we don't get in the pre-hospital setting, that you get more time with this patient to begin with, to see this course of therapy. And like you said, trends tell you everything, and you have more trending time.
Right.
But also being in the facility, these are other colleagues of yours that are going to continue on the care after they come through the ED, and you get a little bit more of the feedback loop and see how people are doing. that we don't get to see that in the pre-hospital setting. So we get this patient sick as can be and shock index of 1.5, nasty. And we go put some whole blood into this patient because we've jumped to the future and we have whole blood here. And this patient gets so much better and their heart rate comes down and their oxygenation improves. All these things improve greatly. There's still the organ dysfunction and damage that happens with that.
Right.
These are long-term effects that we reverse this terrible immediate problem. But that's what you tend to encounter, that we're not talking about shifts in blood chemistry and other organ dysfunction problems that we need to mitigate. And that's a thing that we may see, is that our care is fantastic pre-hospital and on the scene, but there may be some damage that's done.
Right.
And we don't necessarily get to see that. And it doesn't seem to compute for us sometimes that we get the feedback that that patient expired. They did not make it through surgery, whatever it may be. They never left the ICU. And it just doesn't make sense. We're like, but we did amazing things. And they're just some things we can't undo.
Exactly. Exactly. Yeah. They're just like you said it, they're just some things that we can't undo. And this is just, a shock index of 1.5 tells me that patient is incredibly sick. And one of my faculty, when I was in residency, a very, very wise man, once told me that our patients get themselves so close to the edge of the cliff that anything we do to try to bring them back a little bit is a victory. And sometimes, we can only bring them back so far. It's just like in, for example, in stroke, there is brain that is damaged at the moment of the event, and there's nothing that we can, there's brain that dies in that moment. There's nothing we can do to bring that back. It's the penumbra. It's that tissue that is in jeopardy that we can potentially affect. And so sometimes patients have, done things to themselves that happened at the point of injury before we were ever called. There's nothing that we can do about that. We can only give them, the best chances that we possibly can with the tools that we have. Yeah,
we come out of school as pre-hospital providers, all of us, with this falsehood that we're going to fix people. We do our mega codes and they got a pulse back and they woke up and
right.
It's not realistic.
We come out of med school thinking the same thing.
Oh, great. Okay, not just us.
Not just you.
Well, let's just dispel that myth. And I think it's a more reasonable goal in our therapy, like you said. Like this sage wisdom coming through is not to fix problems per se, but to make things better.
Right. We can mitigate damage.
Yes. So we keep it from getting worse. We try to make things a little bit better. And there are a lot of times that, we don't fix the problem. And it's really weird. At least where I came out through school, we weren't taught that. They're continuum of care is just kind of like a buzzword that happens. But legit, the quarterback can't score all the touchdowns. You need the other players on the team.
Right.
So, okay. I think we go round and round about it, right? I want to give some examples of shock index.
Okay.
And we can talk about those. And then I hope to share some professional examples with us too as this come up for you. So let's take a blood pressure of 110/60. I'm big on context. What's it mean in context, right? I can't look at isolated. So a blood pressure of 110/60, I would not be alarmed about 110/60.
No, not at all.
In itself. This person's heart rate is 100. I really have a hard time being very concerned about a heart rate of 100.
That's something that's really easy to pass up, right? Like your systolic blood pressure meets the 3 numbers test. Your heart rate meets the second number is 0 test. Totally easy to look right past those.
And that one comes up because I did the math ahead of time. That shock index is 0.9.
So
we're into concerning.
We're in that potential increased mortality range.
This is, holy cow. What an eye opener that we wouldn't have thought. Let's go even further. Let's say 110/70. Fabulous. 110/70 is great. Heart rate's 120. Again, one that I think a heart rate of 120 might get my attention, but I'm not, holy cow, I don't need the cavalry yet on a heart rate of 120.
It's just because of their pain, right?
Yeah, they're a little anxious. They're nervous.
They're a little anxious and in pain.
Shock index of 1.1. So now we are even over the danger zone is here. We have passed it. We're gone. We took off.
Exactly.
And the last example of it, something that I think would cause us some cognitive dissonance as EMS providers with the way we're taught to look at this, that a blood pressure of 110/60 with a heart rate of 150. That's our shock index of 1.4. Profoundly shocky patient.
Right.
We'd worry about this 150, but for some reason we wouldn't think about it in terms of the blood pressure because it's 110 systolic. The blood pressure's fine.
Right. Note that the blood pressure never changed in any of this. I apologize. Note that the systolic never changed.
Right. And that's so this is the key here to clue us in, the canary in the coal mine.
Exactly.
I really like that expression. That where we traditionally wouldn't have been concerned about a blood pressure and I would not have been concerned about a heart rate, that we need to start thinking about them together in this blood pressure heart rate combo.
Right.
Now we have a concern, or we don't have concern.
Right.
One caveat that we need to make sure we mention in this is the patient presentation. That a normal person with a heart rate of 100 and a softer blood pressure looking at you without massive blood loss, without other indications of hypoperfusion, let's be a little bit smarter about it. That
Right.
it may not be telling you a problem. It's just an evaluation tool.
Let's investigate why. Did they just run a long distance? Were they just in a car accident and they're, all their epis running, they're all amped up?
Yes. Oh, so let's remember. So we talk about it classically with the hypovolemia here, like you mentioned, in trauma cases. There are other generalized uses of it. There's even some literature that talks about using it in asthma, which was really interesting to talk about the severity of what you're looking at in asthma.
Okay.
There was a bit more digging I had to do to really, not for this conversation, but I thought that was a really interesting one that it talked about. It's just a severity scale, period. So we don't necessarily need to be limited to shock. But today we're talking about shock itself and the hypoperfusion end. Do you have some situations from your professional experience where shock index has been important, played a role? Just what's it look like in action in the ED?
Yeah, for sure. So I can think of one patient in particular, an older gentleman who was on a riding lawnmower and rolled it over. It kind of falls under the 100 ways that working on a farm can kill you.
Sounds like a good book.
It does sound like a good book, doesn't it? 100 Ways to Die on a Farm.
Like Final Destination kind of stuff.
There you go.
Okay.
There you go.
All right, so he comes into CU.
So comes in, has a systolic of about 100 and a heart rate of 105. Now, those numbers by themselves, super easy to ignore, right? But when you look at them together, that's your shock index of just over 1. And there are some other things in someone who, especially like an older patient, that should help you clue in to why those not so grossly abnormal vital signs are concerning. So this particular patient had a heart condition. And so what does that often mean?
Oh, some medications that control his heart rate, I bet.
Exactly. Something like beta blockers. And so I'm kind of working in some of the caveats, some of the limitations to the shock index. There are things that we do to patients and there are conditions that patients have that can make this less effective. Although in this case, he was on beta blockers and his heart rate, he still managed to mount a heart rate of 105. So 105 on a patient that's beta blocked, that's a
concern.
Yeah.
Wow.
So maybe they're just inadequately beta blocked, or maybe their body is giving its last hurrah before they start to very obviously fall off the cliff.
So did this guy have massive external hemorrhage? What kind of injury presentation did he give you?
He did. He had just below the knee an almost total amputation.
Okay. Yeah.
Yep.
So something you would expect, right? Again, you look at this, pretty significant injury, very noteworthy injury, but heart rates, blood pressures, Classically, we'd looked at him like, this guy's pretty darn lucky. He's doing okay.
Right. Instead
of he's dying. You're especially considering that medical history, the medications involved. Also, keep in mind the the beta blockers in there. We got rate control issues. We also have the hypertension medications that when the body wants to respond to increase the blood pressure, we have chemical resistance to that no. We're going to go with that.
Right. Those get in the way when you're in a major trauma, when your body really could use some blood pressure.
Yeah. And let's be honest, because it's one of my favorite things that I've taken from you, that our patients have God-given right to have as many things wrong with them as they want, that you may have
many as they damn well please.
There it is, right? It may be rate control and blood pressure control. You may be dealing with both of these together, and you got a really sick patient that's made worse by their long-term care medications and
exactly. It's a hot mess, right?
I love it. Hot mess, right? If it was easy, it wouldn't be fun.
Precisely.
Let's talk about some of these limitations of this.
Okay.
And like you had mentioned some, so beta blockers, of course, are this massive limitation because it essentially invalidates one of your numbers. It becomes a very inaccurate reading of what we're actually measuring. What else do you see as this is great, but? What are some of those buts for you? What are some things that give you pause?
Well, there's always the context, right? Just like, every time I work out, I meet SIRS criteria. If I have a good, solid workout, I'm probably going to have a shock index of greater than 1. And so just looking at your clinical context, you always have to keep that in mind. Another thing that we probably should have pointed out a little bit earlier, this only works in adults. This falls apart in kids whose heart rate is often higher than their systolic blood pressure. Yeah. And so that's something to keep in mind. There are some kind of modified pediatric shock indices. I think it's kind of beyond our scope to go into those. But there are, calculator tools that you can use if you're really interested. But just the classic down and dirty, easy to remember heart rate over systolic only works in adults.
And actually, there's some literature that talks about how we get older in our geriatric population. We kind of lose accuracy too because of the way the body changes in its compensatory mechanisms and its ability to compensate. That it may be a little bit more bleak than the shock index tells us as we start getting to the 60s, 70s, 80s, older than that we get the 80-year-old that falls, hip pain. We take a look at it, short and rotated, all these things. Heart rate's okay, blood pressure's okay. Shock index is, 0.8. I'm going to pay attention to it. I'll make sure to tell somebody that may not be an accurate representation of what we're looking at just because of the age and how that goes. So we kind of get it at both ends, that the book ends pediatric end, we definitely lose accuracy. But as we get a little bit older, again, the context plays a very big part of that and taking in this clinical picture and a full-on assessment. This is not any kind of substitute for the rest of your assessment.
Right.
Let's make sure that's very clear. And if you're worried about a shock index, because I will never miss an opportunity to push it, check your end title. End title is going to tell you whether you are or not on the right track.
I should have added that in my intro. End title is my favorite vital sign.
Ditto. It's fabulous. It'll tell you so many things.
It tells you so many things.
So if you are worried about your shock index, or you can't remember what the formula is for shock index, and you're like, I don't know, systolic blood pressure and heart rate, they're pretty close, and they're not supposed to be that close, I don't like it, and your end title pops up at 14, guys, you're dealing with a shock patient.
Right.
Okay, especially in the face of massive blood loss. You're dealing with a sick trauma patient.
Right. Look at your clinical clues. If you've got signs of blood loss and you've got all those things, something is going wrong.
And this is a great one that you will have young people who compensate far better and will maintain a good mental status in a shock state while they're compensating. They're able to tolerate that a little bit better. And that's very deceiving that we look at them. I'm talking to them just fine. And this is another tool to go back to my fun little expression that patients don't suddenly deteriorate. We just suddenly notice. And I say it tongue-in-cheek, but it's because we don't know what we're looking at. So if we're looking at the 21-year-old who sustains some massive blood loss, has some softer vital signs, but is awake talking to us, we would typically discount that. This person's fine. They're doing great. Sure, we'll drive them downtown because they're doing fine now.
Right.
And then suddenly they stop talking because their shock index was a 1.3. They were tolerating it for a little bit. And now they are done tolerating that.
Right.
And it's caught up with them. Where our older population we'll start losing that mental status capacity a bit earlier in these cases.
Kids are particularly notorious for that. Kids do great until they stop doing great.
Yeah. Those are tough.
They are
It's
very
unnerving.
tough. Yep.
You had mentioned that this has some application in sepsis. Anything more to add to it? Some caveats with it? Have you used it for a lot of sick patients coming in with this just nondescript altered mental status that feels warm?
Yeah. I think the caveats are the same. Sepsis tends to be an older population. And so all of those things that we talked about in older adults that can discount this number tend to play more of a role in sepsis. Our trauma population tends to be younger. Our sepsis population tends to be older. And so all the same caveats. But yeah, it works great in that altered mental status patient who's, got a fever, they're not quite acting right, probably have a UTI. It always takes forever to get the urine, and so you're not quite sure what you're treating yet. If their shock index is approaching 1, you should really, that should raise your alarm bells for something like sepsis as opposed to the viral syndrome, viral syndrome NOS versus sepsis. When the heart rate is creeping up and the blood pressure is creeping down, that points me in the direction of sepsis.
Okay. So even as not even as a gauge of severity, but even a little bit helping nudge in a diagnostic direction as we're working differentials too. That's a fantastic tool. And I wish I had pulled a few more points out, but anaphylaxis and asthma, like they talk about, I thought it was really interesting. Especially anaphylaxis makes a little bit more sense because if it's pretty severe, we head down to a distributive problem with the vasculature becoming permeable. So we can get the same kind of thing. Again, children, a little different, skews our scale, but we get the adults experiencing a reaction with a shock index of 1.2. Let's be worried about that, and let's be ready to treat that aggressively. Let's talk about, I think we talked about all the points. Talked about reference ranges and how people compensate better, but we get too young, alters our results. I love taking vital signs of kids and using it to make a point about context. Because if you have a patient with a heart rate of 140, would you be concerned?
Depends on how old.
Right. So that's always my favorite when people are like, 140 is concerning. But if it's a 1-year-old, it's not an alarming heart rate. If you have somebody who's breathing 32 times a minute, right? The infant, the 40-year-old, right?
Right.
Same kind of thing goes that, hey, you have a heart rate of 80. 60, heart rate of 60. People are like, that's fantastic. Normal heart range is 60 to 100. But that's also your infant. I'm worried about an infant with a heart rate of 60.
That's,
So reference ranges are a starting point. They're not an absolute. Context is crucial. And shock index is just another one of those things. It's as great as it is and as useful as it's going to be limited.
Right.
The context matters. Why are we getting these numbers? How are we getting the numbers? Really, that should be our question for any vital sign that we're looking at. And without a good clinical picture that aligns with it, it becomes an anomalous finding. But at the same time, we have all these different limitations, all these different things that affect the number. So it's not an absolute.
Right.
Just because somebody has a shock index of 0.6 does not mean that they're not a shock patient. It just means that their vital signs are not presenting in the way that is captured by the shock index.
Absolutely. So. Yeah, it's a tool in the toolbox. That's how we should think about it. It's a tool in the toolbox. It tends to become abnormal a little bit faster than either the heart rate or the systolic blood pressure, one or the other by themselves. And so, like I said, canary in the coal mine, it helps you see what's coming just a little bit faster.
I agree. And we absolutely should be rolling this into practice. And we talk about the reference ranges, the 0.5, the 1.0. I think the very functional thing to take from this, like you had said, that heart rate and systolic blood pressure should not be the same. We don't like that. Heart rate should be less than our systolic blood pressure. So if you're even like, is it which one over the other one, whatever it is.
Right.
The higher your heart rate, the more expensive that blood pressure is. And it shouldn't cost you that much. If we're doing all right and we're healthy, it shouldn't be that expensive of a blood pressure.
Right.
So we can even just take that.
If your blood pressure costs $1, then
I like it.
yep.
I like it. Okay. Dr. Humphreys, I really appreciate your time and your thoughts about shock index today.
Absolutely.
Are there any other closing comments you want to throw in there? Parting words for us today? Resounding endorsements for the shock index or other comments?
I think people love controversy, and everything has controversy surrounding it. You're going to find people who are naysayers of the shock index. But in my mind, it's just a tool in the toolbox.
Mm-hmm.
It's just something to look at it in conjunction with your blood pressure, in conjunction with your heart rate, in conjunction with the whole clinical presentation and the patient's history. If they're on beta blockers and their heart rate is 90, even if they've got a systolic of 110, that shock index doesn't necessarily sound any alarm bells, but it's something that you should be thinking about. So this isn't replacing anything. It's just another tool in the toolbox.
Yeah, just another layer of evaluation on something we already have.
Yep.
Well, excellent. Well, Doc, I really appreciate it.
Yeah.
Thanks for joining us today.
Absolutely. Thanks for having me.
And then we will catch y'all next time. Thanks for tuning in.